when we're talking about the snow-plowing effect in perforator-bearing segments, I'll just start right away. The effect is called the snow-plowing effect because of the similarity to these big machines who just push the snow away from the main road and don't care whether they occlude the side branches and the small side roads and the entrances to houses and whatever. And I think our PTA balloons are very strong, and that's why it's nice to compare them with this snow-plowing effect. And if we look at the amount of perforators that can arise from an M1 segment or from the basal artery, it's really impressive how many vessels arise from these segments. So what is the nature of these perforators? In ICAD, perforator infarcts account for approximately 25% of all strokes. And there are a couple of publications who divided the mechanism of stroke, such as this one where perforator strokes accounted for 21 and artery-to-artery embolism for 46. Other, like in situ thrombocclusion, 19%, hemodynamic only 1%, which seems to be pretty low, I think. And another trial by Lopez Cancillo from 2013 found also more than 20% being caused by perforators. And if we look at the location and comparing anterior versus posterior circulation, we see that artery-to-artery embolism accounts for 52% in the anterior circulation versus 34% in the posterior circulation, and it's the other way around with perforator branch occlusions, where 12% account for strokes in the anterior circulation and 40% for strokes in the posterior circulation. So apparently, as some of the speakers also stressed today, perforators are mainly responsible for strokes in the posterior circulation. So Sampras, I just want to highlight one thing that that changed, that local perforator infarcts accounted for 12 out of 224 patients, which is approximately half of all complications. And the authors state that distal symptomatic embolic stroke as an immediate complication of angioplasty and stenting was uncommon. So we're really talking about bleedings and perforator strokes and not about embolic complications in this study. I'll skip that. The weave trial, the visit trial, we've seen that today. And so I'll just go through some examples of perforator occlusions, symptomatic and asymptomatic. This is a proximal symptomatic M1 stenosis before treatment, and this is after 2 millimeter PTA. And this is after stenting with a neuroform stent. Very nice angiographic result. And this is the MR post-interventional. Luckily, this patient recovered very well from this basal ganglia infarct with MRS 0 at 6-month follow-up, but still it's quite a huge infarct that was probably caused by one of these small perforators that we can hardly distinguish here. Another proximal M1 stenosis. Looking at perforators, I would say there are certainly 2 distal M1 perforators that arise exactly on the opposite side of the temporal branch. But in the proximal M1 segment, there doesn't seem to be that many perforators. So treatment was performed and the patient had no infarct. So it was nicely predicted that this procedure would go well. Again, M1 stenosis. Are there any perforators surrounding the M1 segment? The majority of them seem to be in the proximal M1 segment, so there's not a big matter of concern, but it's also hard to say whether one of these crossing vessels in the distal M1 segment is a perforator or not. And this patient had a basal ganglia infarct, but it was asymptomatic, and the angiography result was very nice. Before, after, I don't see any occluded vessels. So getting to the posterior circulation, we have the basilar perforators that are the rami ad pontem and the circumferent or transverse pontine arteries. And arising from the V4 segment, we also have medullary perforators that are corresponding to the and that give also rise to the anterior spinal artery. And this is a case of a basilar artery stenosis and a very small ICA arising from the proximal portion of the stenosis. So I think everybody would agree that a strong dilatation could cause an ICA occlusion in this case, at least, if not any other perforators. So we decided just to place a microcatheter inside the ICA, which is a 17 microcatheter, and then go for angioplasty, just to keep the ostium of the vessel open during angioplasty. And that was the case. We still see the ICA after the procedure, and we had 2 very small DWI lesions in the ICA territory. So side branch occlusion, of course, is not evidence-based at all to protect it with a 17 microcatheter, but at least it could be an idea to have something inside the vessel to protect the snow-plowing effect. Here we see a very, I can't point on it, a very small perforating artery that originates from the normal diameter V4 segment. I hope everybody can see it. It's seen on both planes right at the beginning of the stenosis, and certainly it's an important medullary perforator. But there was no concern for dilate because this perforator was arising from the somehow healthy vessel segment. So PTA was performed. On the left side you see again pre-PTA, on the right side post-PTA, and the perforator is gone. It's not visible anymore, and it was a catastrophe. The patient had this paramedian medulla oblongata infarct, and still on 6 months follow-up, he was in a bad condition with an MRS score of 4 points. Again, a case of a rising side branch, V4 occlusion with a big pica, and same procedure. It was protected with a small microcatheter and then PTA'd and stented, and it remained nicely open. This is a symptomatic basilar artery stenosis just below the ICAS, and here was no concern because it was really below it and it nicely stayed open. So to conclude, cautious indication and selection in perforator-bearing segments have to be made, and we really don't have any strong predictors for whether we are going to occlude perforators or not, even if we think that we are on the safe side, because in the segment we don't see any perforators. So we should concentrate on hemodynamic relevant stenosis, on recurrent infarct despite aggressive medical management, as we've discussed today, and of course the acute therapy in the setting of mechanical thrombectomy. Thank you.